at Kings County Hospital. His career features a commitment to providing high quality urological care to the underserved communities of Brooklyn and a commitment to the education of residents. An early adopter of the robotic surgical platform in Brooklyn, he continues to promote general and minimally invasive urological services at the UHB. In his new role as Director of Operations within the Department of Urology, Dr. Hyacinth supports our parallel missions of resident education and outstanding special patient care. Dr. Hyacinth is the Associate Professor at SUNY Downstate Health Science University, Department of Urology. He's also Director of Operations at SUNY Downstate Health Sciences also. He is highly educated. In just a few, he gained his master's in business administration for School of Business in Temple University and at the University of Pittsburgh's School of Medicine in Pittsburgh, Doctor of Medicine. He also is resident to urology at Lenox Hill Hospital. He also did training in Research Fellowship, Department of Urology in New York Hospitals, Cornell. These are some of his educational achievements. And so this afternoon, he's going to present to us information that would be highly regarded, especially for the men, in prostate cancer. So sit back and listen. If you have questions, I'm sure you can put them in the chat or you can write them down because they will be given an opportunity for question and answers. So thank you as you give your undivided attention this afternoon. I see someone else who is there.
So good evening.
So
good evening, everybody. So thank you for the great introduction. And it's part of our mission, as you mentioned, is the mentoring and development of the next generation of doctors. And consistent with that, I'd like to present to you Dr. Arturo Holmes, who is our chief resident in urology at Downstate. He's scheduled to graduate in June of 2022, and he's been accepted to a prestigious fellowship in further training in endoscopic urology out at Washington, right, Arturo? University of Washington.
Yes, sir.
I've been proud and honored to witness his trajectory, and so part of my mission is to introduce this young doctor, and so I yield the floor to him, and I'll be available to provide any other insight or questions as the evening progresses. Thank you.
Hey, I would actually like to share a PowerPoint presentation. So I need the ability to share my screen if possible.
All right, try now.
Okay, can you guys see my screen? See my
Yes, sir.
Excellent, excellent, excellent. So it is an absolute pleasure to join you guys this evening. Thank you so much for having me, and thank you, Dr. Hyacinth, for yielding the floor to someone, you know, that is not quite as senior as you, you know, but that does have a few aspirational goals to live up to the opportunities that that you guys and your ilk have afforded me. So thank you. So it's an absolute honor and pleasure to speak with you guys this evening. So tonight we'll be talking about something special, you know, something important, rather, especially to this community and folks with a Y chromosome, specifically prostate cancer and what we need to know about it. So again, I'm Dr. Holmes. Dr. Hyacinth is with me, and we're speaking from SUNY Downstate. So what is the prostate gland? So it's essential, it's an essential male reproductive apparatus that basically produces semen, which is a portion of the fluid that's seen in when men ejaculate. Semen is also part of what mixes with sperm during ejaculation to help provide it with nutrients. Here we can see an image of the prostate gland. Can you guys see my mouse? Can you?
Yes, we do.
Yeah, yes, we can.
Yes.
Can you put it on the presentation mode?
Yes.
Make it just to make it a little bit bigger.
Let's see.
Okay,
What if,
just go ahead. Go ahead.
let me change. Give me 1 second. Okay, is that better?
Bingo.
Okay, give me 1 second. Okay, this is good. This should work. Okay, but you guys can see this? Okay, so what is the prostate gland? We see that it's this organ right here that sits in between the bladder and the penis. Part of your urethra actually runs through the prostate. Here, as we're talking about what some of the ejaculatory fluid comes from, the seminal vesicles right here. And it actually deposits in the prostate, in the prostatic urethra, and is expelled out of the urethra and outside. When we talk about cancer of the prostate gland, we're mostly talking about the peripheral aspect of the prostate gland, which is where prostate cancer is most likely to develop, which is why, and we'll get to this, part of the screening techniques that we use is to do a digital rectal exam. But we'll get there. And as you can see, the prostate is right next to the rectum. So this slide kind of brings to the forefront how prevalent prostate, or rather how significant prostate cancer is in terms of other cancers. If we look at males, because males have prostates, 19% of estimated new cancers in 2017 alone. In 2017, 19% of those were estimated to be prostate cancer. So it's a pretty significant disease. And then as far as deaths, we can see from this slide that 8% of estimated deaths were projected to be from prostate cancer. So this is important because there are several different sources that say several different things. All medical professionals don't always agree on everything. And prostate cancer has actually been a point of contention between us. It's important to kind of emphasize that as urologists, we're really involved we're intimately involved in the treatment and management of this disease. Not to downplay anyone else's recommendations, but we are the ones that actually treat the disease when it's most susceptible to treatment, which is why, it's a bit of a point of contention when the United States Preventative Task Force actually initially gave it a grade D recommendation, which kind of, it really moved folks away from being screened from prostate cancer. And prostate cancer is such that if you catch it early, there are several different ways that we can treat it. But if we wait too late, our options become limited. So as far as how we perceive it in the American Urologic Association currently, for men that are under age of 40, we recommend that you don't screen for prostate cancer. And this really looks at kind of a global picture in an effort not to screen or to treat people who would not necessarily benefit from treatment. Anytime you treat a disease, you have to think about what are the benefits of treating this disease, and then what are the detriments that can come of it? Like how will it progress? And are there really bad side effects from treatment? Also, we don't recommend routine screening between men in the ages of 40 and 54 years old. And for men that are older than 70 or with a short expected lifespan, we don't really recommend treatment either. So there's kind of a very special group that we actually target for treatment of this disease, for screening and subsequently treatment of this disease. So as a SUNY downstate urologist, we've actually seen that there have been changes in kind of the prostate biopsy practices. So as less folks were being suggested for screening, there were less prostate biopsies, being done. So that was really a point of contention for us, because then you see folks come in with a disease that could have been treated, surgically or with radiation, while it was contained in a certain area, it becomes, metastatic, or it moves to other places and it's no longer amendable to the same treatment modalities as it would have been before. All right, so prostate cancer, approximately 161 new cases of prostate cancer are diagnosed. So this is something that is very prevalent in the African American or Black community. Actually, as far as recommendations for screening goes, if you are a Black male, then you are actually recommended to be screened earlier than your non-white counterparts. That's because it's been shown that Black men may have more aggressive disease, or a disease that isn't necessarily isolated as easily on standard practice, on standard kind of screening practices. So as far as how we screen for prostate cancer, one of the tools we use, I mentioned briefly the digital rectal exam, but another tool that we use is the prostate specific antigen. So the prostate specific antigen is a protein that's produced by the prostate cells that's only made by the prostate. So we can use this as a surrogate to see if the prostate is producing excessive amounts of this protein. As men age, the prostate gland does grow in size. So, you expect the number to go up, but there are thresholds by age, which we use to help us delineate whether it's gone up too high or too not. If it's too high, then we biopsy, or we may do an MRI. But, this is kind of one of our tools to kind of look out for the potential of prostate cancer. This is another screening practice. I know it's kind of every guy's fear, especially in our community, as far as if we go back to the earlier slide, you can see that the rectum is right next to the prostate gland. So when there is prostate cancer, it can be right here at the kind of this posterior or the back aspect of the prostate. So if the finger actually goes up, you can actually feel changes in the prostate gland that are suggestive of cancer, which brings us to this, this slide. So yes, we do digital rectal exams, and it's important. It's an important part of the screening tool, because sometimes the PSA level may not go up that high, but we can actually appreciate an abnormal contour or abnormal shape of the prostate that lets us know that cancer may be there. And this is something that we might need to investigate further. As far as how we actually figure out whether or not there's prostate cancer or not, if you look closely at this picture, right at the kind of the tip of this needle, you see how there's this change, this kind of changes in the prostate. What we essentially do is there's a small probe that goes up posteriorly, all right, and then there's a needle that actually transverses the rectum. We give local remedies for this, or we give local anesthesia to kind of reduce the pain and the discomfort. But whatever case, we use this needle to take small samples of the prostate gland, so we can then assess those samples to see if those samples are cancerous or not. The actual grading of prostate cancer has evolved, but simply put, what you look for, or what we're looking for, what the pathologists rather are looking for when we look at these cells, is how normal are the cells? Do they look like healthy, round, normally shaped prostate cells, or are they small cells that seem to be rapidly dividing, that are, you know, shaped strangely? And based on how unusual they are, or how normal they are, we give them a grade. And those grades range from 1 to 5. 1 being normal, 5 being very abnormal, being cancer, essentially. And then, so we take kind of, and then after we take all these specimens, we classify kind of what is the most common type of cell we see. So is it mostly 5? Are they mostly like really unusual looking cells, or are they mostly 1? So you can have, you know, a sample that is a lot of very unusual cells, that's 5, and you can have the second most common cell that you see is a lot of, I don't know, somewhere in the middle. You're not really sure if it's normal or abnormal, so 3s. And what we do is we essentially put those two numbers together. So it'll be 5 as, you know, whatever the primary one is, or whatever you see the most of. And then 3 in that case, because that'd be the second most common type that you see, to get a number that is 8. And that would be kind of the Gleason grading system. Currently, a Gleason grade of 6 or higher is what we consider prostate cancer. And there are, you know, prostate cancer grading from there has evolved significantly as we actually use grading, this grading to help us classify prostate cancer in terms of risk, whether it's very low risk, intermediate risk, favorable intermediate risk, high risk, very high risk. There's a bunch of different categories and caveats that we look at it. So this kind of brings us to this slide. Actually, I want to go to this one. So there, as I was saying, there are multiple different risks. This was an earlier kind of risk stratification system, but it's evolved even from this. If I go back to the last slide, something else that we look at, you don't really tell this from the prostate biopsy, but if someone gets an MRI of you or of the prostate, or after they've actually removed the prostate, what we can see is whether the prostate cancer is, or the prostate cancer is contained within the prostate, or whether it's actually extended beyond the prostate, or whether it is about to. So as you can see, T1 disease is kind of localized. It's inside of there. And then all the way up to T4, it's actually invading. This up at the top is the bladder. You can see it invading the bladder. You can see the edge of the prostate gland is irregularly shaped. These are things that we look out for on imaging. Oh, and then one more thing back on the scan, on this slide. If you look at the bottom, you can also see these pictures of folks' bones. So when prostate cancer is localized, all the prostate cells are within the prostate. So if we give certain sorts of how should I say, types of contrast, or types of media in the veins, we can actually see if prostate cells have moved throughout the body, and those will light up, or rather show dark spots in areas where there wouldn't normally be, would suggest that prostate cancer may have moved and is no longer localized into the prostate gland. So kind of going back to what we were talking about before, how the American Urologic Association feels, in contrast to how the U.S. Preventative Task Force felt prior. One of our constant struggles as surgeons, as physicians in general, and as folks that are equally concerned about you, and for the patient as well, is kind of figuring out what is best, what will give you the best balance in terms of treatment of the disease. So, you know, of course, we want everyone to live as long as they can, but we don't want to do something to you that is going to significantly impact your quality of life negatively. So we're always looking for that fine balance. There are multiple treatment modalities for prostate cancer, including surgery, including radiation, including surveillance. Active surveillance is something that we use for lower risk disease, whereby we serially do biopsies, as well as we serially follow the prostate specific antigen to see if there's changes in it, if it's increasing rapidly. We also, take those biopsies in intervals to see if your prostate cancer score is going up or changing. All these would be trigger for intervention in active surveillance, but this is typically something that we do for disease that appears low risk on imaging and on the actual sample of tissue. Surgery is something that we typically, that it's curative, and we do this when prostate cancer is localized to the prostate. There are times when there may be something called a salvage prostatectomy that might be done, but those are special circumstances. Another treatment modality that is available is radiation, whereby there is no surgery, but for all of these different procedures, all of these different treatment modalities, there are risks associated with them, whether that's leakage of urine after surgery or after radiation, or there's narrowing of the urethra itself, or there is issues with ejaculatory function, or issues with erectile function as well. So these are all things that we have to really think about and balance when we're thinking about treatment modalities. And then, there's always active surveillance for lower risk disease. But again, if you're not actively intervening, there's the risk that the disease could, progress. So that brings us to this slide, as we're alluded to. So surgery is the complete removal of the prostate gland. Historically, there were multiple different ways to take out the prostate that we utilize regularly, most of which were open, and then eventually laparoscopic, so being at bedside with small handheld tools. Today, the standard of care for prostate removal surgically is robotically. So we basically inflate the abdomen, dissect the bladder away from the abdominal wall, and eventually procure the prostate and take it out of the body and reconnect the bladder, which is this organ up here, with the urethra down here. Because you can see that the urethra actually goes through the prostate. So when you remove the prostate, you're removing a portion of the urethra. You have to reattach the bladder to the urethra. Also, when you take out the prostate, you take out the prostate itself, you take out the tumor, and then the seminal vesicles are also removed, which are those organs that help produce the semen, to help supply nutrients for the sperm. This is important because, as we kind of discussed earlier, the PSA is a protein that's produced specifically by the prostate organ. So after this is done, we can measure the prostate specific antigen to see if it's being produced elsewhere, which we would consider abnormal. So I kind of alluded to this. We had open prostatectomy. So when we took out the prostate using open surgery, and then laparoscopic, where we did it at bedside using small tools and inflated the abdomen. And then subsequently, we're currently at robot-assisted laparoscopic radical prostatectomy, which Dr. Hyacinth actually performs. So some of the great things about robotic surgery versus open. So, the advance in this procedure or advance in surgery is no small feat, and it's pretty outstanding, actually. So using robotic surgery to remove prostates has actually reduced the operative time. One of the major concerns formerly of removing prostates in an open fashion was that, and what I should kind of frame this, open means that you make a larger incision in the body, and you kind of dissect down. Robotic means that you're making small, tiny incisions and putting robotic arms into the abdomen to reach the area of interest without making larger cuts. You're also using a camera to visualize where you are in the belly when you're doing robotic surgery. So kind of taking a step back. So using the robot has actually, because it's more easy to get to the prostate, you can see it more easily, as well as places that would bleed. You're able to do the procedure quicker. You're able to see places when they're bleeding, exactly where they're bleeding more and more efficiently. You're able to burn them or suture them if you need to more efficiently. So there's less blood loss. You're able to spend a lot of time accurately connecting the urethra with the bladder. So that helps us, have a really good anastomosis or really good connection between the two, and we're able to remove the catheter earlier. Also, patients tend to, because this, when folks ask me what, if they're getting surgery, what I would compare it to, I say it's kind of like getting hit by a truck. So, the difference is you're getting hit by a smaller truck, so you get up a little bit quicker with robotic surgery. So the hospital stays tends to be a little bit shorter, and folks tend to be able to go to work a little bit sooner. So this is the robot. You can see the robotic arms, but these basically go inside of the abdomen, and we use these as tools to isolate and remove the prostate. All right. And these are some more images of that. So you see, even though it's a robot doing the surgeon is still in the room. They're sitting at the console right next to the patient. There are other members of the surgical team at bedside, if anything were to happen, to help control bleeding or to help reposition the robot if there were some sort of malfunction. And there are screens so everyone can see what's going on in the belly as it's happening. This is a really amazing advent to surgery, given that doing open surgery, if you are not in the right place, then you can be out of view, and only those people that are doing the surgery can see the surgery. Versus now, if Dr. Hyacinth is doing a prostatectomy, Dr. Hyacinth can see it. I can see. The other residents can see. So all these extra minds are there to assist and chime in if there is anything of concern. This is to show the small incisions that are made and kind of where we make them. So that's 8 millimeters. So you make 10 millimeters and 8 millimeters and 5 millimeters. All this is to say that these are very small incision sites. This is a picture of an important aspect. So this is the urethra right here. This is the prostate. This is us kind of dissecting around the urethra. Most likely before we've tied off correct me if I'm wrong, Dr. Hyacinth, but before you've actually tied off the dorsal venous complex.
That's correct. And the prostate's already separated from the bladder, which would be out of view and above at this point.
Mm-hmm. So this image actually looks like the urethra has been transected, and he's actually, is that still prostate down there? It looks like it's still prostate down there.
Yeah, it's just demonstrating, things that can be done, things that you can do in typical surgery, tie, suture, cut, you can do quite easily with the robot.
Yeah, so these are all things that you can do open, but the thing is, it's much more difficult you don't have the same level of visualization, and the robot helps facilitate that. So this is kind of what happens after the prostate comes out, and you see the prostate down there, and it's in a bag. It's isolated from the body, and all the tools have been removed. And this kind of brings us to the conclusion of this presentation, because as I alluded to earlier, after you take out the prostate, there should no longer be the secretion of those antigens. So from this point on, at this point, we've taken a major step to hopefully eliminate prostate cancer, but we have to continue to screen for it afterwards to make sure that, we've gotten all of it or it's not recurring. So we really watch our patients for the entirety of their lives to make sure, we can do whatever needs to be done to give them the best quality and to prevent the progression of disease. That's about all I got for you guys today. The floor is open for questions.
Okay, this is Miss Herbert. I have a question about the robotic surgery. I know that during the old system, the patient used to bleed a lot when they had have to do the prostate surgery. How is bleeding with this robot? How, is it less bleeding or with the robot?
So there's significantly less bleeding with the robot. And that kind of takes us back to this. I took us back to this image for a reason. So one of the issues with open surgery with the prostate is that if you can imagine a bowl, no, if you could imagine a vase and trying to clean the inside of a vase, it's very difficult to see where you're cleaning, right? Because the vase is so deep, right? Am I making sense?
Yeah, go ahead.
It's so deep. So when you're doing open surgery, it's kind of like you're operating in a vase. So although there may be places that are bleeding, it's very difficult to isolate where exactly, to pinpoint where the bleeding is coming from. And so you spend a lot of time looking for those bleeding places. And that time that you spend looking, while you're looking for the bleeding is happening. So that really, contributes to the blood loss during the prostate. Versus with the robot, as you can see at this point, the prostate has been separated from the urethra, and we're actually about to throw a stitch inside of one of the areas that is very notorious for bleeding during the prostate. So we're actually able to throw that stitch and tie it off before the bleeding ever happens.
I have a question. There is some controversy about having a blood test done to see if you have prostate cancer versus the rectal exam. What is your take on that?
I think both are useful. So they shouldn't be used in isolation, because there are some cases of cancer where the cancer actually may not grow on the outside of the prostate. It may actually grow on the inside of the prostate. It may actually grow inside the lumen. So in cases like that, the best screening test that you might have is the PSA test, is the blood test. Whereas you may also have someone with a bulky tumor on the outside of the prostate gland, but that type of prostate cancer might not be secreting a lot of prostate protein. So, those are kind of two ends of the spectrum. One case where, you may detect prostate cancer using the blood test, but not find it on the rectal exam. And the other where you may find prostate cancer when you actually touch the prostate, but when you actually check the blood levels, it doesn't show prostate cancer. It's not suspicious.
But Doc, I think that the digital examination was more definitive than the blood test, because actually the doctor could feel the swelling right there between the urethra and the prostate there. That's swelling. So I always think that digital was a better test to be, for prostate cancer.
So I'd argue so I guess what I'm saying is that it's important to do both. So I took us back to this picture specifically because I want to kind of emphasize how anatomy and function both play a role in how we determine whether or not there is disease. So the physical exam, the digital rectal exam, lets us know if there's any anatomic change in the actual texture of the prostate. So when the finger goes in where the probe is right now, you can actually touch the surface of the prostate gland right here and feel if there's change. But what if there's prostate cancer right here in the urethra, like around the urethra? In that case, even though your finger may touch the prostate on the outside, you may not be able to appreciate prostate cancer on the inside. Does that make sense?
Arturo, if you can go back to the image of the prostate, I wanted to answer 2 questions in the chat. Someone asked whether doing a biopsy can cause the cancer to spread. That's a very good question. For this particular type of cancer, prostate cancer, the answer is no. There are some cancers where you do a biopsy that there is a risk of spreading the cancer, but fortunately that's not the case for the prostate. Another question that was asked was, what would the impact of prostate cancer or surgery on the prostate cancer have on sexual function? So first, let's just start with how men get an erection. There, in this area here, there are nerves that come from the spine and go between this groove between the prostate and the rectum. Those nerves interact with the blood vessels of the penis. Those nerves secrete a chemical that causes the blood vessels in the penis to open up. You all are, I'm sure, familiar with the drugs Viagra, Cialis, Levitra. Those medications work by enhancing the secretion of that chemical so that they can interact with the blood vessels of the penis for a longer period of time. So besides the stimulating portion of a man getting erection, the next step is the secretion of the chemical by the nerves. In doing the prostate surgery, also in doing radiation to the prostate, you can conceivably damage those nerves and eliminate that crucial step in the erections. Now, one of the reasons why we advocate for early screening is because if the cancer is more confined to the prostate, we can do what's called a nerve sparing procedure, where we can't see the nerve, but we kind of have an idea where it's running, and we can peel that tissue, that portion of the nerve, away from the prostate and try to preserve it. So very often in those cases, we're successful in allowing men to either get erections on their own, maybe not as great, but certainly they respond very well to Viagra, Cialis, Levitra. Now, that used to still pose a problem because those drugs were prohibitively expensive, but thank God for generics. Those drugs are widely available from wholesale distributors, ranging from $2 to $5. If any of you belong to Costco, you can get a whole bunch of those medications for about $1.50 to $2 a pill. So that's one method. The next thing, if the pills don't work, is we can teach you to directly inject a stimulus to the blood vessels so that the blood comes into the penis. And you do it with a needle, and it sounds, pretty bad, but I assure you, it's easy, and I have lots of patients who use it. So what I wanted to get at, the person who asked that question, is erections, or the fear of not being able to get erections, should not discourage you from seeking treatment for prostate cancer. That is very important. We can get you functioning depending on how aggressive you want to be about it. I'll try and read some.
I'm very concerned about the long-term effect of using Viagra and the other medication there. I'm over concerned about the long-term effect.
Those drugs have been on market for 2 decades.
Yeah, they've been out
2
here
decades.
for a long time.
So you have a very good track record.
Effect,
so there are definite indicators. There's definite reasons. There's a definite group of patients who should not be taking it. And those are those patients who have severe cardiovascular disease with the heart. Other than that, it's been demonstrated to be an extremely safe and effective drug. And we have nearly 2 decades of evidence to validate that.
Mm.
There are a few more questions.
Question was, why do the PSA test post prostatectomy if the prostate is producing a protein? So what I'll try and address is, we use the PSA after any treatment for prostate cancer, be it surgery, be it radiation, as a tool to see how successful we have been in treating it. As Dr. Holmes talked about before, the prostate is really the only organ that produces that chemical. No other organ produces that chemical. And so if you remove the entire prostate, it makes sense that you should not be able to detect any chemical in the blood. Now, having said that, you'll get very, very low levels on the order of, a tenth or a thousandth of 1%. So if it increases, if the PSA is still high despite removing the prostate, that's definitely a warning sign that the cancer either can be recurring in the area where we did the surgery, or it's recurring someplace else in the body. So I hope that answered that question. Let me see what else is in the chat. Very important question, excellent question. Please give some early symptoms of prostate cancer, and can a man have prostate cancer without knowing? That is a great question, and that's why screening is very important. I've done well over 300 robotic prostatectomies and in the hundreds of open prostatectomies. And I can tell you with certainty that the majority of the patients I operated on had no symptoms specific to prostate cancer. The symptoms of prostate cancer overlap with what we call benign prostatic hyperplasia. And the symptoms that occur is familiar to any man in their late 40s going into their 50s and 60s. You get up at night to go to the bathroom. Sometimes you have to go frequently during the day. Sometimes you get a sudden urge to go to the bathroom. Sometimes the flow isn't as strong as it used to be. Those symptoms are common to either benign enlargement of the prostate or the development of cancer in the prostate. So it's very difficult to separate the symptoms of benign enlargement of the prostate from prostate cancer. And that's why screening is so important. Let me see if there's any other questions. Where does free PSA fit into the picture of determining prostate cancer? I've never really been a big fan, and this is just my opinion, of free PSA. And in my view, it's probably been relegated to historical context. Why? Because we now have the benefit of using MRI, which is many of you are familiar with the technology of an MRI. We've been able to highly correlate the presence of lesions that carry a high risk for prostate cancer. So if there's confusion with a PSA level that's rising in someone who's had a biopsy previously and we fail to detect cancer, the MRI becomes an invaluable tool. And using that rationale has pretty much rendered, in my opinion, free PSA obsolete.
Doctor, I'm very concerned about these young men coming in with prostate cancer. Is there anything they could do to avoid getting prostate cancer, like certain drugs or diet or something that could be they use to prevent them getting prostate cancer?
Unfortunately, there's been no definitive pathway to preventing prostate cancer. We've looked at selenium, we've looked at using Proscar, finasteride, other medications, and there's unfortunately no medications, no pathway that clearly reduces your risk for prostate cancer. There are some things that may help. a low-fat diet because the relationship of testosterone, cholesterol, and fat content, there is definitely a bond between those things. And testosterone is certainly high testosterone certainly may increase your risk for prostate cancer. So what I would say is generally healthy choices are the best thing you can do. No guarantee of protection. So that would include a low-fat diet. That would include healthy living, exercise, not smoking, getting your COVID vaccine. What else? Avoiding stressful situations and embracing stress relieving activities. And even while those things may not prevent prostate cancer, it certainly will enhance your ability to recover from treatment for prostate cancer.
A follow-up question. Can STDs cause prostate cancer?
Not that I'm aware of, no.
Okay. Thank you.
Another important question. Where does the semen produced go after you remove the seminal vesicle? The semen is no longer produced. So if you look at this here, when we remove the prostate, we remove the entire seminal vesicle. And this structure here, if you can go back to that picture, this structure, so that's the seminal vesicle. And then you've heard the term vasectomy, where you tie off the tubes, quote unquote, tie off the tubes to prevent sperm from traveling. So the vas deferens, which transports the sperm, comes along this way and joins the seminal vesicle in the prostate. So when you remove the prostate, you remove the seminal vesicle and you occlude the vas. So no more babies. And when you orgasm, which is the process, the muscle contracting, that's basically the muscle contracting causing ejaculation. When you ejaculate after your prostate is removed, you'll have little to no material being ejaculated. So that's, so it makes sense that it's impossible for a man to conceive via natural methods. Now, you can aspirate sperm from the testicle and do artificial insemination, but basically from a natural point of view, it's impossible for a man to father a child after the prostate's been removed.
Doctor, another question. I think I'm not talking too much. That's the last question. If a patient had the seed implant, would that affect their function, and would that affect his spouse?
His what? I'm sorry, the last part.
If he had the seed implant, would that affect his function, or would that affect his spouse?
The last thing you said is what? Pouch?
His spouse, yeah, his spouse, yeah.
Oh, his spouse. No, okay. So the seed implant, that's done, basically, you're inserting radioactive pellets into the prostate. And what that does is you get a high dose of radiation in the area where the seed's implanted and a low dose of radiation in the surrounding structures. The important concept to know is that the seeds are not active forever. The most common seeds we use usually lose their activity within 3 to 6 months. So in the initial phase of a seed implant, all we recommend is that a man doesn't have a young child or a baby sit on his lap, because in their formative years, they're more sensitive to the effects of radiation. But as far as contact with the spouse, intercourse with the spouse, the transmission of radiation is, you probably get more radiation from your cell phone or your microwave oven.
Okay.
In terms of impacting sexual function, it can impact sexual function. Even though you're not removing the prostate, the nerves that I spoke about before are extremely sensitive to the effects of radiation. So it's possible that you can have an adverse effect on your sexual function after radiation as well.
Hello? Yeah. Hi, what's up, man?
You having dinner?
No, I listened to the program. There's a program on Zoom. That I'm listening. What's going
Hello,
on?
Lawrence, we can hear you.
Yeah.
Okay.
So good. But she said he's in White Cloud First.
Another question that was the age of screening. I'll let Dr. Holmes take that.
So as far as the age of screening, I brought us back to this slide that kind of emphasizes the age of screening. So we don't screen for anyone under 40, but there are special populations where we do screen earlier, specifically in African-American men. So in African-Americans, because there's a higher risk of more aggressive disease, we may start screening around age 45. And also in males with family history of prostate cancer. So if there's like a first degree relative with prostate cancer, like a father or a brother, then we'll start screening earlier as well, around 40, otherwise 45. Otherwise, we don't typically start screening until age 55.
I have a question. I kind of raised my hand. I'll just say it. So going back to the semen production and being able to father a child, do you have any suggestion for someone who doesn't have any children yet, but would like to get, have one or two, of course, but then they go through this process? Any suggestion as how they could preserve,
Well, fortunately, I mean, that's a good question. And and fortunately or unfortunately, the majority of the men that we take care of are older and no longer interested in having children. But to answer your question, because on the rare occasion you do have men, late 40s, early 40s, maybe starting a second family, or maybe, as you said, haven't had children yet. If that's the case, regardless of the treatment, be it radiation, be it surgery, we'd recommend that they bank sperm. They'd have to contact a facility that cryopreserves the sperm. That would be our recommendation, regardless of the treatment, be it radiation, be it surgery.
Thank you.
Any other questions, folks? Well, we very much are thankful that you had us here this evening, and hopefully we gave you some useful information. Just thank you for the opportunity of sharing, giving us the opportunity to share, our perspective on prostate cancer, and we hope you found it useful.
Okay, Dr. Hyacinth, on behalf of the Health Ministry Department, we would like to thank you for the presentation, and we'd like to thank the resident, Arturo Holmes. I hope I'm pronouncing the name right.
You're doing just fine. Thank you so much.
Okay, thank you. We'd like to thank you for the presentation. It was very clear. And I'm sure everyone has learned a lot. And as you said, we could prevent a lot of things that happens to us. And as someone remarked, African Americans seem to be always in the high risk of everything. So we will hope and we will try to do what we ought to do, eat properly, exercise, and do those things. Go and have checks when the time is right, have our physicals, etc. So thank you again for the presentation, and we look forward to having you again at some point. And we wish you, Dr. Resident Arturo, graduation, I think they said would be next year. You're well on your way to a successful completion, and we wish you all the best. And thanks again for coming and for the information that was shared.
Thank you all. Have a great evening.
You too.
Thanks. Have a blessed evening. Bye-bye.
Bye. Thank you. Why is the recording still going?
downstairs. Yeah? Yeah.